Hi, I am Dr. ARCHANA SUNEJA and I will be presenting to you a case of 31-year-old patient with secondary infertility who came with complaints of severe pain in abdomen in emergency. On per-vaginal examination, her findings revealed a normal-sized uterus with mass in right adnexa which was firm to cystic in consistency and mobile from side to side. It was felt separately from the uterus. Her investigations and markers were done and found to be normal. USG investigation showed a large mass in right adnexa measuring 10 into 10 cm with solid as well as cystic components and was seen involving the ovary. So decision of emergency laparoscopic cystectomy was taken. A 10 primary optical port was placed. On entering the abdomen, this was a large ovarian mass that was seen present in the right adnexa. And then accordingly, rest of the two left-sided accessory or the working ports were placed. Mass was then inspected from above downwards, side to side, to look for any additions and to plan how to proceed for our surgery. There was torsion and some areas of hemorrhage and necrosis seen over the mass. Torsion was 1.5 turns. This is the IP ligament. And we were inspecting for ureter as well. The ureter is down below and it is very far from the IP ligament. This is also an area of hemorrhage. This is the ureter and you can very well see that it is very far from the IP ligament, so we are very safe. So keeping the ureter under vision, visualizing where the IP ligament is, we proceed with our surgery, keeping in mind our distance and our safety with the great vessels as well as the ureter. The fallopian tube was seen in close proximity to the mass and we wanted to save this fallopian tube as the patient wanted to conceive. So we inspected for the other side fallopian tube and ovary as well and it was found to be fine. So we left both the tubes and the left sided ovary. Then we proceeded further onto the mass. And then we were deciding from where to go to secure the IP ligament. This is the IP ligament and the vessels with it. Then we were thinking of putting another right-sided working port, accessory port, but the mass was so big and huge that if we would have put an accessory port on right side, it would have directly hit the mass and perforated it. See, you can see the close proximity of the mass to the anterior abdominal wall. So we decided to work with two ports, two accessory ports and one optical port. Now this is the IP ligament and we started with this. did fenestration first, just the peritoneum of the IP ligament, skeletonizing the IP vessels. We are still skeletonizing the IP vessels, putting our instrument below it to fenestrate the peritoneum from the other side as well. Pushing the instrument further, opening the jaws, rotating the instrument, and thus the fenestration is complete. Fenestration helps you to secure the IP vessels away from the ureter, only the vessels, and tie them meticulously. Now we are using free tie. For tying the IP ligament, we will take one tie above and one tie below, and we'll cut in between them. So now we have tied our knots and will be securing the IP ligament further by using bipolar and coagulating the vessels in between, as well as a little below the knots that we have tied, so that first of all our surgery is bloodless, and secondly there is no risk of hemorrhage. We have secured our pedicle with the sutures as well as with the energy, keeping in mind that the ureter is far away from our site of operation. This is the bipolar current being used, and you can see the movement of the blade just slipping on from side to side, and we'll make a segment so that the vessels are effectively coagulated. Using cold scissors to cut the coagulated area in between, and you can see there is no bleeding both up pedicles as well as towards the mass. the pedicle is safe. And you can see the ureter as well. Your pedicle is very far from the ureter. And you can see the peristalsis also. And we are happy because that's what most of us are scared of in gynae surgeries. Now we proceed to separate our mass from the fallopian tube, as we want to save the fallopian tube. Here we are using bipolar energy itself because there are very big mesosalpingeal vessels and the mass is drawing its blood supply from there. That's why they have become huge, and so we don't want it to bleed, so that our surgery will be bloodless. So we are using the bipolar itself to coagulate and do a bloodless surgery. Now we are dissecting millimeter by millimeter using bipolar energy as well as cold scissors to make our field bloodless. We are just careful in opening the peritoneum only and coagulating as we go further with the bipolar. Now changing the traction, from the other side we'll go. We are suctioning first and clearing our field. Why? Because the red area absorb most light and our vision will be impaired. And we'll go from the fimbrial end of the tube. This is the ultra-precision scalpel we are using here. We'll cut millimeter by millimeter in the peritoneum, not harming or injuring any vessels that come in our way. You can see these broad mesosalpingeal vessels. We are just denuding the peritoneum over these vessels and we'll go parallel to them so that we don't hit any vessels that we encounter on our way, or else they'll cause major bleeding. And see, you can see now our tube is separate from the mass and our mass is free to be retrieved. So now our mass is separate from any attachments. It is freely mobile, free from every attachment, and is ready to be retrieved or morcellated. Now we are clearing for any collection that might have happened on the way. Now creating a third accessory port, right side port, which will help us in retrieving the mass. We widened one port, increased its size so that we could put a bag for retrieval of the mass, end bag retrieval, so that there is no spillage. We'll put an inserter. This is a type of tissue retrieval bag known as a fishnet bag. And as we pull a string from outside, the bag opens from inside and the mass can be put in this bag. And then we can suction the contents of the mass in the bag itself so that there is no spill. First we tried to suction the contents with an aspiration needle, but the contents were so thick that it could not come in the needle. It could not be suctioned by that needle. So then we tried a wide bore needle. We tried with this wide bore needle as well. but the content was so gelatinous and thick, it wouldn't come in this also. Then finally, we used harmonic scalpel to increase the size of the puncture and used a suction to aspirate the contents. We did a thorough cleaning and washing of the abdominal cavity to remove any collected fluid or blood clots from our surgery so that the patient is having a good and comfortable post-operative recovery period. We then took the two ends of the bag outside from the same port which we had put the bag inside, and we opened it and retrieved the contents very slowly outside so that the bag does not burst and contents do not spill in the abdominal cavity. The abdomen was again inspected and the residual fluid was sucked in. The pedicles were checked. And a port closure needle was used to close the port. and then we remove the port under vision and complete our surgery. Thank you.